All right, good morning, everyone. There we go. Thanks so much. It's great to see everybody this morning. The posterior malleolus. Okay, here are my disclosures to begin. So our objectives, we are going to try to define, does size sort of matter in critical decision-making for fixation for posterior malleolar fractures? When is it critical to fix these? And does surgical fixation of the posterior malleolus actually improve patient outcomes? I have a caveat here that this is a highly debated area, so I'm looking forward to some really interesting discussion around this. It's a very evolving area at the moment. Let's start with a case. We have a 31-year-old female. She fell while mountain biking. She's healthy. She works as a physiotherapist, and here are her injury films. So I would encourage you to sort of think, what would you do? How would you approach this? What additional imaging will help you make your decisions? And that's important because most of our literature up until now has really been based on radiographic decision-making to evaluate the size of the posterior malleolus fracture. Why is this important? We know that the posterior malleolus provides not only bony stability, but also ligamentous stability as well. So quite often a posterior malleolar fracture can be an avulsion fracture of the posterior inferior tib-fib ligament, or PITFL. It's important to note that posterior malleolar fractures can actually occur in up to 44% of rotational ankle injuries, so this is common. We're just maybe recognizing it a little bit more. And X-ray measurement, as I mentioned, has been the standard up until recently, but it's highly inaccurate, and we have poor inter- and intra-rater reliability when we're measuring the size of a posterior malleolar fracture fragment. And just to get back to why this is widely debated and clearly an area of evolution, there are 143 classification systems that have attempted to classify posterior malleolar fractures. So does the size actually matter? This is a systematic review from 2023 that looked at all classification systems and can we use this information collectively? But the difficulty is there's such heterogeneous reporting of how these posterior malleolar fracture fragments were measured. So they can be defined as 20% to 30% or a third of the articular surface. And there's so much variability in defining the size of the fracture fragment that it makes really understanding patient-reported outcomes very difficult. So in this systematic review, 9 of the studies reported that surgical fixation of the posterior malleolus was improved, whereas 7 of the studies actually reported that there was really no difference. But I would argue that we really aren't classifying these or speaking the same language when we're describing these injuries. So let's go back to Haraguchi, who was the first to describe a CT-based classification system in 2006. 3 main types are illustrated here: posterolateral, transverse with extension around to the medial malleolus, and type 3, this shell type. This classification actually had a very good inter- and intra-rater reliability. However, there have been several modifications by other authors still struggling to really classify how these, the shape and the morphology of these fractures. And so I would argue here that a better question isn't the size of the fracture, it's the morphology and how it behaves as far as stability of the ankle. So about 10 years later, this classification system came out and it started to help us to correlate what we're seeing radiographically with outcomes. So type 1 fractures on the far left have very clearly had better reporting outcomes compared to the type 2s, which are B labeled here. This classification system had good to excellent inter- and intra-rater reliability. So we're getting closer with this. And type 4 fractures, highlighted in red on the far right, you could almost argue this is kind of a pilon fracture, as we were just learning about, certainly did better clinically when surgical fixation was employed. So how can we kind of put this all together and answer the question that I was tasked with: when is it critical to fix the posterior malleolus? So I'd argue there are 3 main indications, the first being evidence of instability. So this is an obvious example here, but posterior malleolar fractures can be bony avulsion fractures of the PITFL, as I mentioned. This can be a harbinger of syndesmotic instability, but it can also let us know that there may be additional ligamentous instability as well. So we know that surgical fixation of the posterior malleolus reconstructs the bony anatomy, it retensions the PITFL, and it reduces the fibula within the incisura. And that's really important for ankle stability because it allows normal syndesmotic motion. So evidence of instability. Number 2 is incarcerated fragments. So this is very interesting. If you're looking at the Haraguchi classification, 2/3 of the incarcerated fragments that likely need to be addressed are actually associated with that type 1 lateral type posterior malleolar fracture. So hopefully that helps you just have a little bit higher clinical suspicion when you're looking at those particular fracture types. Here's an example where you can see we have this incarcerated fragment. We're going to have incongruent joint, and we're going to have some point loading, which brings me to our third sort of indication, is articular incongruity. So we know if we have a step in a load-bearing joint, this will disrupt the mechanical forces, it'll alter load transfer, and this has a high risk of going on to post-traumatic osteoarthritis. So I think we've achieved our first objective. When is it critical to fix? Instability, incongruity, and then, I apologize, we'll go back one here. Incarcerated fragments, okay? So moving on to our second objective, does fixing the posterior malleolus actually improve patient-reported outcomes? So this is a systematic review from 2023 as well. The outcome measure that has been reported the most is the AOFAS score, the American Orthopedic Foot and Ankle Society score. On this forest plot on the left, we have closed reduction and internal fixation, and on the right, we have open reduction and internal fixation. And so you can clearly see here that open reduction, visualizing anatomic reduction of a posterior malleolus fracture, had improved AOFAS scores in this large systematic review. And similarly, if we compare non-operative on the left compared to open reduction and internal fixation on the right, similarly, you can see with open reduction, visualization, anatomic reduction, these patients did better compared to non-operative management. How about midterm results? So this is a review of 79 patients, CT-based classification. These patients at least had a 5-year minimum follow-up, and those treated surgically for fixation of the posterior malleolus had significant improved functional scores at 5 years. So I think we've achieved our second our objective here of short and medium term improved with anatomic reduction of posterior malleolar fractures. So let's apply that back to our patient, 31-year-old female, fell mountain biking, healthy physiotherapist. I'll give you the CT scan now at this point because we know that it's really important for us to classify the morphology and how this is behaving. So here you can see we have radiographic signs of instability. We actually have an ATFL, anterior avulsion fracture. We can see that PITFL attached to our fairly small in size, but important in morphology, posterior malleolar fracture. And then we can see joint incongruity on the sagittal imaging. So I would argue that our best available evidence suggests that there is improved short and medium term functional outcomes when we surgically fix and anatomically reduce the posterior malleolar fracture. Do one more example, I do have 6-month follow-up for this patient. So this patient was a participant in one of our studies, so I have a 6-month CT, and here you can actually see the posterior malleolus is healed very nicely, the ATFL avulsion is healed anatomically, and we can see the fibula is really nicely reduced within the incisura, so she's returned to full activities. So an additional case here. So this is a 52-year-old female. She fell down some stairs. She does have an elevated BMI. She's a non-smoker, and she works as a teaching assistant. And so here we can see these large fracture fragments, but the morphology of this is really important. If I can get you to push play on my video, we'll have a little 3D reconstruction view of this fracture pattern. Fantastic. Thank you so much. So as we come around the back, we see that there's a direct posterior, but there's also a posterior medial component. We also can note that there's some comminution at the apex of that medial fracture fragment. So here we're really checking some of the boxes for incongruity of the joint, signs of instability, and we worry that this patient would certainly benefit from anatomic reduction. So this patient was treated with imaging of her well leg, so we can really evaluate the syndesmosis, a posterior medial approach that we just saw a really nice review of, reduced fragment-specific fixation for both that medial apex as well as the more posterior direct apex. So we've restored bony stability, articular congruity, and this patient goes on to have an anatomic reduction. So just to review our objectives here, does posterior malleus fracture size matter? Well, I think we've learned that morphology is probably more important. When is it critical to fix the posterior malleolar fracture? Signs of instability. incarcerated fragments, and joint incongruity. And really remember that we want to assess the syndesmotic stability as well. And lastly, does surgical fixation of the posterior malleolus improve patient-reported outcomes? Our best evidence would really support that patients report improved function in the short and medium term with selective fixation of our posterior malleolar fractures. Thanks so much.